pretty similar to the last one. You liked it though.
That scene is apparently when you have to go to the toilet.
I'll do beef this time though. I fancy it myself. Exactly, yeah. It doesn't look like it's going to be a very nice day, to be honest with you, from what the weathers say. Yeah, when it's snowing. Typical, isn't it? Yeah. We can't So welcome back. I hope you enjoyed the short break there. Whether you were using the meet and match function, you can continue to use that, or perhaps you did one of the wellness exercises. You are now joining me in one of the parallel sessions. This is the main studio, but if you want to stay with us in session one, where we're going to discuss what the impact COVID-19 has had on health and gender equality, then stay here. But if you would prefer to join one of the other parallel sessions, the second one being sexual and reproductive health and rights, then you can join Raza in the second parallel session. That is all within the space there, the online session. So you can just move into the second room, or if you'd like to join Alexandrina on mental health, then you can join the parallel session number 3. So feel free to head over to one of those rooms, but if you want to stay with us here in the parallel session number 1, we will get underway with our panel. So the first thing that we're going to do is we're going to have a presentation by Blandine Mollard, who is a researcher at IGA. She is joining us from Vilnius, and we're going to give her the floor to give us an outline of what the sort of impacts have been and what the research has shown about the sort of correlation between health and gender equality. So we're delighted to be joined by you, Blandine, and I will give you the floor.
Thank you, Jack. Welcome, everyone. It's a pleasure to be starting this session on a topic that has had so many ramifications in our daily lives for many months now. It's a heavy topic indeed, as we are talking about lives cut short, about people losing their health or going through trauma and burnout. I'm sure this topic feels most personal to many of us. Before we start, I want to give a few pointers on the magnitude of the pandemic in the EU. As of late September 2021, according to ECDC data, 38 million of people in the EU have tested positive to COVID. This is roughly the equivalent of the entire population of Poland. Over 770,000 people have lost their lives to the virus. And as shocking as this number may sound, it does not capture the full toll of the pandemic, since sadly, the full toll goes beyond mortality from COVID and includes mortality due to delayed treatment or mental health issues. To give you an idea, on average, mortality for men during the period of the pandemic has been 17% higher than in previous years and 14% higher for women. The impact of the pandemic has also been very unequal across the EU and across population groups. Overall, about 8% of the EU population has tested positive to the virus so far. France, Spain, Italy, Germany, and Poland have registered the highest number of cases, from nearly 3 million in Poland to 4.7 million in France. But what we're seeing is that the highest burden of infection is found in less populated countries, especially Czechia, Slovakia, Slovenia, and Luxembourg. To give you a sense of proportion, 16% of the Czech population has tested positive to COVID since the beginning. Also, different groups of people have been impacted differently, depending on various factors, including the level of viral exposure and prior health status. So in this presentation, I will focus on 2 main topics. First, I want to cover the impact that the virus itself has had on women and men's health, with gender differences in infection rates and outcomes. And second, I want to touch upon some of the indirect impacts of the pandemic on health, highlighting 3 specific gendered impacts. As we discuss this topic, we need to keep in mind that there are considerable variation in how data across countries is registered or provided. For example, testing protocols have differed greatly, which of course has affected the number of registered cases. Also, data on testing, cases, and mortality is not always disaggregated by age and sex, which hinders, of course, a comprehensive gender analysis of the pandemic's impact. For this presentation and for the thematic focus at large, we have used health surveillance data from the ECDC and from Global Health 50/50. So globally and in the EU, we are seeing clear gender differences in health outcomes. Although women are more likely to be tested, overall infection rates are quite similar for women and men in the EU so far. As of late September 2021, women accounted for 51% of all COVID cases, and men 49%. But men are more likely to be hospitalized and to be admitted in intensive care units. They're also more likely to die from the virus. At the moment, men account for 54% of deaths from COVID-19. So you see, men represent 49% of the cases, but 54% of the deaths. The graph on the slide shows data by sex and age for 10 member states. Overall, 8% of women and 10% of men infected with COVID were hospitalized as a result. However, both the likelihood of being hospitalized and gender differences increase with age. Among infected patients aged 70-79 years old, 24% of women and 33% of men were hospitalized. But for those aged 80 and older, the rate of hospitalization reached 31% for women and 45% for men. Some of the elements possibly behind such gender differences include biological factors, but also health behaviors, such as smoking and comorbidities, which tend to be a little bit more common among men. But beyond sex and age, understanding the full impact of the pandemic requires analysis of other groups, which are the groups who have been most affected. So if you remember from the previous slides, and I'm not planning to quiz you on the statistics, but infection rates in the EU have been rather similar for women and men. However, researchers have found that when looking at the working age population only, when factoring in the age, infections among women far outnumber infections among men in 10 EU countries. Those sort of conclusions need to be strengthened or reaffirmed. The research is still new, but authors had to attribute this to the fact that women are overrepresented in the care and health professions. We will now look into factors such as occupation, migrant status, or socioeconomic status, which have increased exposure to the virus for certain groups of women and men. You might have noticed, but since the pandemic started, it has led to a massive shift to remote work as a way to slow the spread of the virus. But not all workers were able to telework, and most governments edicted established lists of occupations of who is essential and whose physical presence is required in the workplace. Those occupations were mostly in health and care, in victim support services and law enforcement, education, food production, supermarkets, and banks. Women have been overrepresented among essential workers in the EU. To give you an idea, Eurostat data shows that women account for over 70% of education workers and health professionals, and over 80% of cleaners and helpers. When looking at essential workers, migrant workers also play a key role, and they tend to be overrepresented in some of the low-skill essential jobs. An index of social distancing risks found that the sectors at greatest risk of COVID exposure were accommodation, food services, retail trade, and social and personal services. And even within those occupations already at great risk, groups of workers that were already at a disadvantage, such as women with low education, older workers, and migrant workers, have been placed at extra risk. Globally, women account for an estimated 72% of COVID cases among healthcare workers as of April 2021. And similar findings are emerging from Germany, from Italy, and Spain. Understaffing, poor working condition, and a lack of appropriate safety measure, combined with precarious employment in some situations, have all contributed to really high level of infections in women-dominated professions. There's also very concerning evidence emerging to significant numbers of people having contracted COVID, continuing to have symptoms weeks or even months after contracting the virus. And women of working age, people with disabilities, those living in deprived areas, and people working in care have been found to be more likely to be affected by long COVID. After this admittedly depressing overview of the pandemic's effects on life and health, I would like to say a few words about some of the indirect impacts that we're seeing on health. Of course, the list of health effects of COVID is enormous, and I want to focus on three in particular due to their relevance to gender equality. The first one is the disruption to the provision of sexual and reproductive health services, the rise in gender-based violence, and the deterioration of mental health. The pandemic has disrupted access to contraception for many women due to changes in opening hours or even closure of the clinics, the fear of infection or even movement restrictions. There has also been a lack of information on available services and whether they were considered essential or not, problems of stocks even, and postponement of appointment for long-term contraception. Another barrier that is found to have been brought about by the pandemic has been the loss of income. The European Parliamentary Forum on Reproductive Health has highlighted that pre-existing challenges in terms of access have been aggravated by the pandemic, especially for groups of women who are already at risk of unmet needs for contraception, such as very young women, women with disabilities, and women in rural areas or refugee women. Research has shown that emergency contraception was the most affected, which, of course, can have absolutely life-changing consequences. In response, many EU countries have reacted with measures to improve access. Just to name a few initiatives, in some countries, minors between age 16 and 18 were allowed to buy the morning after pill in the context of the pandemic. Although other examples include telemedicine and remote consultations, prescription for contraceptive posted by mail or available in pharmacies. And now experts and policymakers are advocating for some of those changes to be made permanent. The second impact I would like to touch upon is the fact that the pandemic, and especially its accompanying restrictions, including lockdowns, have contributed to a global surge in intimate partner violence. And some of the reasons include forced cohabitation with an abuser, economic uncertainty, combined with the psychological distress resulting from lockdowns and the pandemic at large. Those factors have often aggravated violent dynamics and led to a rise in violence, including femicide. New forms of control have also emerged as a result of the pandemic, with perpetrators using the fear of contracting COVID as an excuse to control their partner's movements and to isolate them further from family, friends, or support services. And experts have warned that, unfortunately, the peak of this surge in gender-based violence is not likely to emerge until after the pandemic has subsided. The third impact I would like to discuss is a looming mental health crisis. And I know some speakers in the beginning of the conference have alluded to it. Social isolation, the fear of infection, grief, and financial distress have been some of the enormous stresses brought about by the pandemic. Eurofund's survey on COVID-19 has shown a worsening of mental health well-being across the three pandemic waves, with large segments of the population at risk of depression. Women's well-being has been consistently lower, and people with care responsibilities, especially non-parents, have been facing acute tensions in terms of balancing paid and unpaid work, when schools or daycare and support services have been profoundly disrupted. Evidence is also mounting on the profound mental health toll of the pandemic on frontline workers, particularly in the care sector, which is a sector that is already at high risk of poor mental health in normal times. the stress of poor pandemic preparedness, trauma from having to prioritize care and seeing patients suffer or die, overwork, and the fear of infection have all contributed to acute psychological distress, sometimes even manifesting in terms of post-traumatic stress disorders. There is need to really urgently address this mental health crisis, as it may result in more people resorting to unhealthy coping mechanisms, including substance abuse, which is already quite common among young men. The mental health consequences of the crisis, just like what we've just talked about, gender-based violence, are likely to be felt not only for a long time, but to peak only after the pandemic has subsided. So the data and the evidence that we see at the moment could be misleading because it might not be the full picture. To conclude, I want to stress that the full impact of the pandemic on the EU population will take time to emerge. Obviously, the pandemic is far from over, and I'm sure this is something that you experience in your daily life wherever you are. What seems clear already now is that the pandemic has profoundly unequal social and economic consequences. While many were able to insulate themselves from the virus or to mitigate its effect on their lives, essential and precarious workers were placed at much higher risk. Long-term consequences are likely to occur for individuals who have gone through hospitalization or for those suffering from long COVID. So classifying COVID-19 as an occupational disease could help ensure workers have adequate social protection while dealing with the long-term effects of the infection. Given the toll on the EU population combined with aging population, access to affordable and quality long-term care is more critical than ever. A renewed commitment to the implementation of the European Pillar of Social Rights has taken a greater urgency. The pandemic has also highlighted very poor working conditions and staff shortages in the health and social care sector. These will need urgent redress if health systems' resilience is to be strengthened. More than ever, we need ambitious, long-term investment in care systems, healthcare, but also social services. Finally, the secondary impact on physical and mental health will probably and surely be gender-specific and long-lasting. So sustained and renewed effort to promote quality, accessible mental health services is absolutely key. And the EU has adopted very ambitious objectives and strategies when it comes to health. Just to name two, the EU Health Programme and WHO strategy to improve health and reduce health inequalities. But for those commitments to become a lived reality, a clear gender approach to mitigating the impact of COVID-19 is vitally needed. Thank you very much for your attention. I'm looking forward to the discussion.
Thank you so much to Blandine for that presentation from Vilnius. We really appreciate it. So some pretty stark warnings in that presentation. If you are talking about this event and the index on social media, please remember to use the hashtag EIGEINDEX, IGETINDEX. We'll follow the posts as well, and that's where you can continue to post and to communicate about everything that we're talking about today. If you're on the platform, a reminder that you can drop your questions there on the platform and like other people's questions if you'd like them to be answered. Now, let me introduce you to our speakers for our panel discussion. Good afternoon to everybody. We have Evelyn Regner, who's a member of the European Parliament, the chair of the Committee on Women's Rights and Gender Equality, the FEM Committee. Thank you so much for being with us. We also have Janez Poklukar, who is the Minister of Health in Slovenia. We have Isabel de la Mata, the Principal Advisor for Health and Crisis Management in the Directorate General for Health and Food Safety of the European Commission. We have Isabel Yoldi Alguia, who is a Programme Manager for Gender and Rights for the Gender and Rights Office for Investment for Health and Development in the WHO's Regional Office for Europe. And last but not least, we have Professor Sarah Hawkes, the Director for the Centre for Gender and Global Health at University College London in the United Kingdom. So I really appreciate all five of you for joining us. We'll try and cover as much as we possibly can. I'll come to you first, Evelyn, about what the European Parliament's FEM committee is doing. You've seen the results of the index. How motivated are you to ensure the work continues to bring about gender equality when there's only been such an incremental change this year?
All of you from sunny Brussels. During the Gender Equality Week of the European Parliament, we are so much pushing full gender mainstreaming in all committees. And of course, we are always waiting eagerly for the Gender Equality Index, and it is clear focus on health this year. So I was listening right now with huge interest and looking very much forward to the debate. And we can look, when we just look at the situation on health and the Gender Equality Index, that here, when you're just looking back from the beginning, the figures were in comparison to other sectors quite well, but hardly moving. And of course, Corona does a lot right now. So we know on the short time, men are more affected. Death rates of men are higher throughout Europe. But on the long term, it's women's health that is affected more likely with long COVID, and who, on the other hand, are also more likely to get vaccinated. So somehow, interesting situation. One of the most important takeaways we have in the FAM committee, in the Committee of Women's Rights and Gender Equality, is the secondary effects, especially care, have been shared unequally, weighing mostly on the shoulders of women. So we also heard the data on health in general. Access to health services in the European Union is still not universal. So more than 3% of women and nearly 3% of men report unmet needs for medical examinations, with people with disabilities, low education, and aged over 65 being affected even more. Socioeconomical situation has a major impact at one's health. That's not a new information, and the importance of the social pillar and to really push it and to go on with this, the necessity at European Union level was mentioned, so it's good. And let's not forget the increased number of violence during the lockdown also has an impact on especially women's health. So I would like right now, amongst all this, what has been put on the table right now, mention two issues specifically, two aspects of health specifically. One to address mental health and loneliness, and the other one, sexual and reproductive health. Loneliness and the whole mental health issue is a topic I've been working quite for a while now, and currently the Commission is doing a study on it. I initiated it. Such a horizontal issue that the first side Commission somehow doesn't feel so properly knowing who is really responsible, but now there is a commitment, and I hope and wish there is a lot going on in that. The effects on mental health are specifically and especially significant, may it be young people who stuck at home, starting university, not having a chance to get out of the surrounding just at an age where you need that. Of course, also the elderly women who just scared of getting out. So somehow this is really a big issue. The mental strain was and is. Let me remind you that the pandemic is still ongoing, especially heavy on healthcare workers, really on healthcare workers. I have to put that out again and again. And the second aspect I would like to talk about is the access to sexual and reproductive health. Here we in the European Parliament really have made a strong statement. This is so important. During the pandemic, the access was often temporarily restricted. In Austria, where I'm coming from, thanks to an initiative to a colleague of mine, Penny Bayer, that there are alternatives were found with the adoption of medically induced abortions. And therefore, let me remind you here that abortions are an integral part of the health of women. So denying the access to safe and legal abortions is violence against women. And insofar, an important topic at this stage when talking about women's health. But access to health, to sexual and reproductive health services, especially for women and girls, had already been difficult in many member states before the pandemic. And you know all that about whom I'm talking. It's one of those fields where more action has to be taken and which we'll have to understand that this is an important part of health in general. So what to do now? As politicians, as the European Committee for Gender Equality and Women's Rights, let me just
Evelyn,
address
let me stop you.
increasingly topic. Yes, I just say one.
Okay, carry on.
Just simply a fair and sustainable care economy, because this is right now, in the context of health, the important message. Care services are central in all our lives, and this is really the important topic: childcare, elderly care, caring about ill people. So this is the political conclusion out of all the health issues.
I only wanted to stop you because we were going to press on with sort of what's going on and what we need to do in the future. We'll ask you some questions
Yes.
about that shortly as well. Turning to you, Minister, obviously, unfortunately, Slovenia is the one country on the index this year that has actually sort of slid back on gender equality. What did you learn from the pandemic? And Minister, what are you going to try and do to reverse that trend?
Thank you, first of all, organizer, for invitation to this conference and the chance to exchange our experiences. We haven't noticed any major differences in access to care for women and men in Slovenia this regard. One of the advantages of our system is primary reproductive health care. Specialists such as obstetrics and gynecologists, which are directly accessible for women and cover all key aspects of reproductive health protection, including family planning, contraceptive counseling, and preventive checkups for pregnant women. Primary reproductive health protection and its good accessibility, even during the pandemic, was crucial for protection and women's reproductive health. It's important to mention the vaccination coverage against COVID-19. It's interesting, women are less likely to get vaccinated than men. This is largely due to concerns about the long-term impact on health, side effects following vaccination, and the opinion of excessive pressure in relation to vaccination. Among persons questioned in our research, 58.3% of men and 51.1% of women received 2 doses of COVID-19 vaccine. However, women showed greater responsibility to their loved ones, as more vaccinated women than vaccinated men reported being vaccinated in order to protect the health of their loved ones. Also, the pandemic has shown that staff reinforcement are needed in healthcare to enable smooth operation of prevention programs and to improve the health and social care of the elderly. The Ministry of Health is currently addressing the situation in this area with a new bill on long-term care. There are also new investment in health needed. The act in this regard has already been adopted. Work from home has been proven as a good solution, which brings added value also for the environmental, traffic, and economic issues. While it should be regulated to allow the workers their private life, it is positive that also EU is dealing with this issue. Thank you.
Thank you so much, Minister. We'll turn to you, Isabel de la Mata, from the European Commission. It would be good to know, what did the Commission learn through the pandemic about gender inequalities, and what are you doing to try and sort of change the tide and try and improve the situation for equality for women?
Thank you very much. We have learned a lot about everything during the pandemic. I mean, we have learned a lot about health. We have learned how the health impact the economy, but in real terms, not in theory as we were saying before. And we have learned how this pandemic have affected different groups of population and women and men in a different way. Many things have already been mentioned. The long-term COVID for women, more mortality for men, more women taking care of elderly and other groups, and being in the most exposed employment, so being more affected, but men dying and having more severe COVID and being more in the hospitals. And that we need to respond to the different needs of the different people in a different way. We have been trying to pass this message for many years, that women and men have specificities, biological, behavioral, and others that need to be addressed in a different way. That there are groups of population that are more vulnerable to different diseases because also of biological factors, but also the way that they are living, the knowledge that they have, the health literacy that they have, and that we need to address that in a different way. So the Commission has launched different strategies and also a gender strategy, and to work at the European Union level, and now there is something transversal of mainstreaming that we try to apply to all our policies, and including for health, and even we are going to measure for the first time the budget that we are dedicating to those genderized policies in all the domains, including the health. It's true that for many years we have been saying that we applied needs-based policy for women and men and etc. But I mean, this was something that we were saying for everything, was already a common talk. Now we are really trying to apply that. The pandemic has had an impact in the whole population, has affected severely everybody, young and old people. Mental health has been and is being and will be a problem that we need to tackle, and that we are going to do. We are trying to work also on that, but also for chronic patients, for example, that they couldn't follow the treatment during the pandemic. They were not seen by the doctors. Even the screening programs that have not been mentioned yet. For cancer, especially. I mean, we have screening programs for three main kind of cancer: cervical, breast, and colon. Two of them are essentially women cancer, or more frequent the breast cancer in women. And so we will see the impact in the future. The women that were not diagnosed of this cancer in an earlier stage, and that will suffer from the disease in the future. That could apply to many other diseases that affect also men. But I mean that the immediate effect of the pandemic, we have learned about that, but we will continue to learn, because the effects we will see in the medium term and even in the long term. Even for the excess of mortality, we have some ideas, but the statistics, we will not have the definitive statistics until 2 years' time. So there will be a lot to learn at that moment. Yeah. And we are putting all this learning into practice and into policies. And I have to say that this time is true. We are acting, we are trying to do gender health or respond in a specific way to the specific needs of women and men, and also other groups. and concentrating in the acute phase of the disease, but also to the indirect consequences of the pandemic. As I have said, I want to insist in the chronic patients because they have been very affected, but also things that we don't have to repeat again, never again. The services, essential services that have been closed, the primary health care that has suffered, and even the vaccination program, the regular vaccination programs have been impacted. We need to reverse that and to work more on the resilience of the health system to be better prepared to respond to the needs of women and men. Thank you.
Thank you so much, Isabel, for those opening comments. We'll turn now to you, Isabel Llordia from the WHO. The WHO has been pretty critical, I think, of the preparedness of health systems and the responses from health systems, sort of broadly to the pandemic. What are you telling governments and institutions like the European Union that they need to do to be better prepared?
Thank you, Jack, and thank you, everyone. I first want to really send a very warm thanks to the European Institute for Gender Equality. We have been collaborating in the past and working very much to give some nuances to the domain of health, because we knew that the domain of health always came as the highest levels of equality, but we knew that there were very strong areas that were missing from that domain, like sexual and reproductive health and mental health. So we are really happy that this has been addressed. I think that yes, WHO has been at the center of the political debate as never before. And as Isabel de la Mata said, COVID has put health in the agenda, in the political agenda, in the economic agenda, in a way that has not been done before. I think that the previous sessions of this conference show that. That now health is there as a very strong determinant of well-being, and the interlinkages between social, economic recovery and health are there. What we are saying is that a little bit what we have been saying for a long time, but now together with COVID, gender has been put on the health agenda at a higher level. Funnily enough, or not funnily enough, but the first signs of gender being given attention was that there was a higher mortality among men. And that has put the light of there are differences, as we know that there are in most of the diseases that we are looking at. And so the first thing that we are telling member states, and WHO has a broader region than the European Union, but to all member states, is just look at what's happening and why, and look at your data. The research agenda has never been gender responsive. We've known for decades, and it has been a constant claim of research on clinical trials, on the vaccines, on the treatments, that need to have that equal participation of men and women to be sure that they are equally effective to men and women. We want to have the data. We don't have the data. We have presented some of the data. We have some on mortality. We know that we have some on hospitalization, but we don't have the full picture. Isabel says that we won't have it for the next 2 years, but in some cases, the disaggregation of data is not there. And Sarah Hawkes, that comes after me, has had a big impact on promoting that. So this is the first thing that we are saying: have the data right. The minister mentioned that there is women are more reluctant to the vaccination. For which reasons? We need to have that data in order to know what to do. So that's the main a key one. The other one is that has been shown also on the during COVID is invest on your workforce, invest on your health and care workforce. They have been suffering tremendously. And it has been a pandemic, and we are seeing already that some countries are going back to the situation pre-pandemic in terms of working conditions, investment on gender equality, but investing in general on the workforce, which is fully feminized, but it is a pillar of our work. And the last one, if we have just short messages, is that what are the essential services? And we have been mentioning what it is, the gender dimensions of the essential services, pre, during, and post-pandemic. So why don't we have sexual and reproductive health services at the core of our essential services? Why don't we have violence prevention and dealing with violence against women at the core of our list of essential services? What do we do? What will happen with several of the screening programs, as it has been mentioned? So the data, the research, knowing what has happened and for whom has happened, men have died more, who died in the care homes, what is the excess mortality due to? I mean, why are we having more hospitalization? Is a biological issue for men? Is it related to comorbidities? Is there a not reporting of death among women? We do need to know that in order to build the services around it. So data, services, and the health workforce are three of the main issues. They are not all. The mainstreaming encompasses the policies and on the whole health system recovery, but I think that these three are crucial. Thank you.
Thank you, Isabel. Yeah, lots and lots of work to be done to pull ourselves out of this pandemic. I'll just, we haven't got much time left on this panel already, so I'm just going to encourage, if you'd like to ask questions to any of our panelists, write them in now as soon as possible, and I'll start putting them to the panelists shortly. We'll turn to you, Professor Sarah Hawkes. What has this pandemic shown us about gender inequality from your point of view?
Thanks very much, Jack, and thank you again to the organisers for the opportunity to talk with you all. I mean, I think from our perspective, and when I say our, I'm talking about the organisation that I co-direct, which is Global Health 50/50, that Isabel Jordi-Aguirre just spoke about, which is an advocacy and accountability initiative within the global health sector. What we have really learned over the past 20 months of the pandemic, first of all, is that gender really matters to health outcomes. And, you know, given the age and the stage that we are in our lives and careers, we knew that already. But I think that COVID has really helped tell that story in a way that it's been almost impossible to tell that story and have attention paid to that story for almost any other health condition. So as has already been mentioned by Isabel and others, you know, COVID's not unique in the fact that gender is playing a really big role in people's experience of this pandemic. So almost any health condition that you can name, gender will be playing its part. So I think what the pandemic has highlighted for us yet again is the importance of gender and gender equality on not just the risk of whether people are vulnerable to a disease, but whether they then have can realize their right to the services and inputs that they require to address that disease. But I think that what the pandemic has really shown for us in Global Health 50/50 is the remarkable absence of sex disaggregated data. So we like to think that we live in the age of rationalism, where evidence plays a very important role in policy making and in policy responses and program responses. But we know, as people who study decision making, that clearly values and ideas play very important roles as well. And what's become very clear to us is that even something like COVID, where there's been a huge influx of resources to control this pandemic, that we are still in a situation where in Europe, our data shows that in Europe, only a third of countries are currently telling us the sex breakdown of who's getting a vaccine. So we've heard examples of, overall it might be more women, it might be more men, depending on the national context. But as far as we can see in terms of what's available to the public, it's only a third of countries that actually report that data. It's well under a fifth of countries that tell us actually who is getting hospitalized by sex or gender, let alone when, it's become very clear that it's not just about your gender, it's about your position and your power and your privilege in society. And so it's about how your gender interacts with your age, your class, your occupation, your ethnicity, your ability status. None of that is being represented in the vast majority of data sets. So as much as we've got evidence, really, we've gone on leaps and bounds at the submolecular level to be able to understand this virus, develop biomedical interventions that are finally beginning to bring the virus under control in some societies. We haven't really got off the starting blocks in many countries to even give us the most basic information, like, is this a man or a woman who's dying? We haven't got that data for about 30% of deaths worldwide. We don't know what was on their death certificate. Was this a man or a woman who died? And that's a travesty. That indicates to us that despite all of the pleas and the commitments that countries have made, that they're still not delivering on the most basic information that allows us to have these discussions.
There's such a lack of data, and it's really exposed the pandemic has to that lack. So we are really running out of time already, and we've only just got into our debate. So I'd like to plead with you all to give just as short answers as you possibly can so that we can get to as many of the questions that have come in as possible. We're going to turn to you, Minister. I think this is probably a question that you can answer. The question is from our audience, we hear about major gender gaps in COVID-19 pandemic-related statistics. In your opinion, Minister, what gender statistics would be most important to collect? We've just heard about the lack of it, and monitor in order to know more about the long-term consequences of the pandemic on women and men?
Thank you, Jack, for this important question. I would first say that in Slovenia, we have a new resolution on the national program for equal opportunities for women and men for the period 2021 to 2030. And this resolution, I think that will give us answers to this question. Various activities will be implemented for its realization in 6 priority areas, which are, on the first place, working relations, family relations, and social welfare. Secondly, education. Third, health, which will be focusing on improving the health of both women and men and aiming towards reducing inequalities in health between men and women. Violence against women, decision making, and external affairs. Then I also have to mention that Slovenia, as the member state holding the presidency of the Council of the EU, together with other members, is working intensively on projects European Health Union. This is very important. This will strengthen the 2 institutions at the EU level, European Centre for Disease Prevention and Control, so-called ECDC, and European Medicine Agency, EMA. At the same time, we went to establish the HERA coordination mechanism to increase cooperation between countries in tackling cross-border threats. Slovenia is also working on implementation of the Europe's Beating Cancer plan.
Yeah.
Thank you.
Thank you, Minister. Sorry, I'm going to cut in just so we can get through as many questions as possible. This one I'll put to you, Evelyn, that's come from our audience. Can you explain the main priorities of the EU health programme related to COVID-19 and its effects on EU citizens? Are there any recommendations or measures which aim to improve gender equality? I suppose we could also ask Isabel that as well, but I'll start with you, Evelyn.
I mean, I just put it on like this. I'm coming from the Women's Rights Fund Committee, so there is always this women's approach. We need simply more, and this has been already very well shown, more facts, more figures, more data in order to build up. We realized it so many times, and this needs a better interconnection of all institutions among the European Union working together, and care. I refer very much to the RRF, the Resilience and Recovery and Resilience Fund, that when we are just about to judge right now the national action plans, but I think it's really, in most countries, a mischance. There lies a big potential in it, and I'm looking very much forward to the Commission when there is the monitoring process to be very strict on really looking at exactly those health measures for women, facts, figures. Investments on care are really in there.
So let's put that same question to you, Isabel de la Mata from the European Commission. Can you explain what recommendations or measures are sort of concretely there and what you're doing internally in the Commission as well to try and make this a reality within the institutions?
Okay, the health program is not the only one that is going to deal with the consequences of the pandemic and the COVID-19. So even if it's a very important in numbers this time, I mean, we have grown from 460 million euros to 5.3 billion for the 7 years. It's not the only one. The program has 4 main strands: the preparedness, the prevention of the disease, the health systems, and the digital, and with an horizontal measure that is the cancer. So in all those areas, we are taking the gender equality into account, not only in the cancer program where this is very evident, and we are measuring how the women and men are accessing the health services, how the screening programs apply to both of them, how is the recuperation, the treatment, and etc. in women and men, the differences. So in all the other strands, we also take into account the gender differences. And as I have said, for the first time now, the Commission as such, all the DGs, we are measuring the budget that is applied for how the budget is benefiting women and men in a different way. So the genderized budget, say like that. For the first time, we will have something at the end of the year already available. I have to say that for DG Santé, we have the meeting with DG Budget next week. So it's quite important for us, and we are working on that now. So we hope that we could make the difference really now in this period of 7 years of the program. And internally, this is one thing, but also we are applying ourselves, and we have a task force on equality where all the DGs are discussing about those issues and try to see how we are applying in each service, in each general directorate in the Commission, the gender strategy that we are requesting the member state also to follow. So it's a big effort. It's not easy. There is no. We are not used to do that. I mean, just apart from having numbers of how many men and women are occupying different posts, but as has been mentioned by the other speaker before, the data are really important. We need data. If we don't have the data, we don't know how it's going, the health of women and men, and how we are advancing, and how the pandemic or other diseases are affecting women and men. So we need the data disaggregated by sex or by gender, the different data, and how the different diseases have affected to women and men, and why women and men have reacted differently to this pandemic from the health point of view and others. Thank you.
Thank you very much indeed. Sorry, we're really running out of time and there's a lot of questions, so I'm going to try and get to as many as possible. I'll come to you, Professor Hawkes. Just as quickly as you possibly can. You talked about the need for like data and the reason that you know there's such a lack of sex disaggregated data. The question is this due to a lack of political will? Why is there such a lack of data? If you can answer as quickly as possible.
Sure. I think, to be honest, we're in quite a vicious cycle with the lack of data, in that what we have really failed to do over the past many years is show that if you take gender into account, that it makes a difference to health outcomes. So, I'm not totally blaming the people who are responsible for data systems that they don't disaggregate because they're not being told to, because we haven't made the case. We haven't had enough research to show, or evidence to show, that taking gender into account will really make a difference. So when we look at policies globally, we see only 9% of health policies for COVID that actually take gender into account. And presumably it's not some sort of willful neglect. It's because there is a lack of evidence that this is going to make a difference to issues of equity and effectiveness.
Yeah.
Combined in some places with, I think, people simply not misunderstanding, not knowing that gender is such an important driver of health status.
Thank you so much, Professor Hawkes. I think we still have Blandine with us as well. I understand that she's still available to us for a question, and one has come in to her. The question to you, unfortunately, we don't have Blandine. So that question we'll have to. You'll be able to ask the experts after this session, so we can. You'll be able to try and get in contact with her. But so we'll move to you, Isabel Jordi-Agria from the WHO. One of the questions that's come in is, by which concrete actions do you think that health policies make sure that gender equality considerations are taken on board, also for migrants and applicants for international protection and refugees who are living in Europe? Because this is a big issue of today, is trying to consider not only the people that are sort of immediately within the system. I wonder if you can answer that.
I want to make a point also about the data.
Carry on, please. Yeah, feel free.
Also related to that, because we call for more data. I just want to say also that the data exists. When you go to the health service and to the local area, the data is being collected. It's just not being reported and not being used. So we have the data, but sometimes the disaggregation gets lost on the reporting places. In some cases, it's true, it's not collected. But we have known for a long time what it is the impact of gender and health. And it's true that we needed to make it more systematic. But we have had research on cardiovascular diseases, we have had research on mental health, we have had research on gender and blindness, we have had research on health systems. So I think that it is a combination of definitely a call for the disaggregation of data, but the use of the data that we have, which sometimes gets lost on the way. And it is not also to underestimate what it is the extra step you need to do in order to make analysis and use that data. So it's a whole process of using the data that we already have. We don't have to wait. We need the data, but we don't have to wait much more to take action. And in how to take action also on the health policies, we have also got guidelines and work on that, on what we call the dual approach, right? The twin approach. We do have a systematic mainstreaming, as Isabel de la Mata says, that DG Sanco is now doing with the health program. What it is, the systematic mainstreaming of health policies, from gender budgeting to analysis of the health workforce, to investing money where the gaps are, and then targeted actions depending on what the policy priorities are. I think that one of the mistakes that was done in the past is like the gender equality priorities in health went in parallel to the core health policies, and we need to combine both. If violence against women is not a priority of the health sector, it needs to be there. But if the priority of the health sector is non-communicable diseases, gender approach needs to be there. So to combine that dual approach on health policy and programs. I think that with the migrants, probably the EU colleagues will be more able to respond to that. But I think that when we talk about gender, we are not talking just about men and women. We are talking about men and women from different groups. And migrants is one of them, as it is ethnic minorities, sexual orientation, gender identity.
Isabel, I've got to stop you. I'm really, really sorry, and I wish we could put that question to the rest of you. But this being a parallel session, we've run out of time, and we're going to join the whole event back together. So I'd just like to give a huge thanks to you. I know we've been pressed for time, but to Evelyn Regner, to Janusz Poklukar, to Isabel de la Mata, Isabel Jordi Aguirre, and to Professor Sarah Hawkes. Thank you so much for joining us. I wish we had more time to expand the details. Thank you for being with us today.
Thank you.
Okay, so that wraps up our parallel session. We will continue to ask you. You can continue to put your questions within the platform online, and continue to use the hashtag EIGE Index. We obviously now have the results of the Gender Equality Index for 2021, and there's far more information on the website which you can find out there. So we will just have a brief moment now while we wait for the rest of the parallel sessions to join us. We'll take a quick second before we enter our closing session.